I've been involved with Frailsafe right from the very start of the project, before it was even called Frailsafe. At that time, the British Geriatric Society and its then president, Finbar Martin, wanted to start working in a real quality directed way. Tom Downes had had the idea of a checklist to improve the acute care for older people visiting hospital.
How we got to the collaborative is a 4-year story. Frailsafe started as a good idea. Just 2 geriatricians sat together wondering how we could improve the quality of older people's care. We knew about checklists improving safety in the airline industry. We'd studied and understood how that had been translated into surgical operating theatres, and we posed ourselves a challenge. Could that be translated into the complexity of acute medical care of frail older patients?
The British Geriatric Society has been supporting Frailsafe for a couple of years now, since really quite early on in its development, because we believe it's an important initiative to try to improve care for frail older people.
This is a great opportunity that the Health Foundation is allowing us to undertake, having won a grant from them. We're bringing together 12 hospitals to try to develop and learn how to implement a safety checklist to improve the reliability of frail older people's care in our acute hospitals.
We know how to prevent these adverse events. It's by doing simple things well. We know how to prevent people falling over, how to stop them getting clots in the lungs, how to stop them getting pressure ulcers. We don't always do the right things, not because we don't know what to do, but because we forget to do them. We get caught up in the complexities of care.
They're more likely to stay in hospital for longer. We know that them receiving specialist care early on actually improves their chances of a good outcome. With Frailsafe, we're not trying to get people to do extra things, and that's been one of the things that we've been emphasising throughout the teaching session. We wanted to design something that anybody could use, whether or not they actually have an interest in the care of older people. Frailsafe is working as a check and challenge list, a trigger tool. If our work is successful, we will have a tool that works, that doesn't create extra bits of paper, but actually improves and directs care very easily.
Frailsafe's undergone a lot of development in the last 2 to 3 years to make it as simple and as usable as possible, but so far it's only been tested in a small number of hospitals, and we're keen to learn more about how it can be implemented across the wider NHS. The steps that we're starting here in Sheffield today will allow a wider variety of medical and nursing teams to try the tool, to test the tool, and to work out really how effective it can be in practice and what we need to do to make it effective in practice.
Now we're on version 8 of Frailsafe, and it's looking professional. It has an evidence base behind it, and at the collaborative here we have 12 hospitals who are about to go into the real world and test Frailsafe and try to get it to work properly.
They represent a mixture of teaching hospitals, district generals, small hospitals, large hospitals, and people from around all 4 nations of the United Kingdom. And we've brought that sort of variety of healthcare teams together so we can understand how Frailsafe works in different settings. 12
hospitals have already expressed how much they're learning. They arrived with an enthusiasm. They thought this was wonderful and we're going to spread it through their organisation rapidly. But by teaching them improvement science and teaching them about what the mechanics are, the science behind Frailsafe, they're changing their view. They're now thinking about how they're going to start this small, how they're going to test Frailsafe at a very local level and measure it to see if the change they're making is an improvement.
What we need to obtain though is evidence that it works. Once we've got the evidence that it works, we've already got enthusiasm, but what those enthusiastic sites need, even those that aren't pilot sites, is need evidence to be able to take this and convince their board, their governors that this is the thing to be doing.
I think there's been some real shared lessons learned across the different areas from the country, and I think it's been really beneficial to hear everybody's similar successes so far and similar challenges.
It's more thinking through the issues of frailty and how we're going to apply it in our context under the headings of the Frailsafe tool.
Clearly adverse events are not just bad news for the patients, they're bad news for the National Health Service as well. The NHS spends a lot of money getting people better after they've had falls, after they've had clots in the lungs, after they've developed pressure ulcers. It spends, for example, on pressure ulcers £4 billion a year alone on helping get patients better from those. If we could prevent those happening in the first place so that they can get a better service, a more responsive service and a higher quality of care. And although Frailsafe is a relatively simple intervention, we believe it has the power to move hospitals to a situation where they might be better able to do that.
So in 10 years' time, I would like Frailsafe to be internationally recognised in the field of geriatric medicine particularly, but also in healthcare. I would like somebody who's being admitted to hospital in Canada to have their relatives asking the doctors there, are you using Frailsafe?